Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. wildhealth.com for all the information on becoming a patient or working with us. Good morning, Thursday, July 2nd. Thanks for joining the Wild Health COVID update. We're going to give you some news updates and then jump into some literature as well. Some really interesting stuff on antibody formation, which is important. It's going to be really important moving forward. So as of today, we have over 2.7 million cases and 130,000 deaths in the United States, approximately 10.5 million cases and 515,000 deaths worldwide. Data from the Financial Times shows a sustained increase in coronavirus deaths over the past few weeks. The rolling weekly average of daily coronavirus deaths remains at 4,500 deaths a day, several hundred more than last week. South America continues to account for 52% of average global deaths. Brazil has consistently reported more than 30,000 new cases a day, the second highest daily incidence in the world after the United States. The United States has reported more than 40,000 new coronavirus cases a day for the past several days, the highest daily incidence worldwide and far exceeding the previous peaks seen in April. According to the New York Times database, the number of new cases has increased by 80% over the past 2 weeks. Tuesday marked the highest daily case count yet, with more than 48,000 cases confirmed that day alone. This is the fourth time this week that the U.S. has broken its own record. On the same day, 8 states also reported their own record-breaking number of new cases. More important than cases are hospitalizations, and hospitalizations have also been surging, particularly in states with accelerating outbreaks like Texas, Arizona, and California, further confirming that the rise in cases is not due to increased testing. We've been saying that for the past week or so, that we don't believe when we look at the numbers that it's just increased testing. In 7 states, average hospitalizations have increased by at least 25% from last week. Contrary to some people's reports, the rate of positive tests is also increasing steadily, so the percentage of tests that are positive. This is a really key indicator of how widespread testing is. And as testing increases, the rate of positives should go down. And that's what would happen if we were just seeing more cases because of more testing. The percentage of positives would go down, but that hasn't happened. So data from the COVID Tracking Project, which has been tracking tests at the state and national level for months, shows that positive test rates in 27 states are up from 2 weeks ago. So during a Senate hearing on Tuesday, Dr. Fauci testified that the number of new infections could double to more than 100,000 new cases a day if the outbreak continues on its current trajectory. He explained that half of all the new cases are being recorded in just 4 states: Arizona, Texas, Florida, and California. Talking about vaccines, the FDA has released some additional guidance for companies seeking FDA approval for COVID-19 vaccines. Among other requirements, in order for a vaccine to receive the approval, it must be able to prevent disease or decrease disease severity in at least 50% of people who receive the vaccine, which I thought was an interesting number, Mike. Do you think people in the public in general are thinking that they're going to get a vaccine that's good 50% of the time?
I don't know. I never, you talk about like the things that you swear against talking about. It's like, what is it? Diet and religion. Are those the 2 things? I think vaccines is somewhere up there with me as well. Not that I don't believe in them, but I'm just like constantly like blown away by how much negative press vaccines get. So I try not to make assumptions about what the public's going to do when it comes to vaccines, but certainly 50% is not a great number to be working with.
Yeah, and this with the flu vaccine, it's not always that helpful. It doesn't always cover the strain, and so flu vaccines are not perfect. And I think people understand that, but I think when I hear people talking about vaccine, they're talking about this whole pandemic being over when we get a vaccine. But if it's able to prevent the disease just over 50% of the time, then that's a different story, and I don't think people are thinking about it that way. So it still would be incredibly helpful for getting to herd immunity, to say the people that potentially already had it, plus those that get this, and you get 50% of those. But there are some questions about immunity even after infection, which we'll talk about a little later as well. But
50% though,
important.
50% doesn't sound great, but when you think about it from an epidemiologic standpoint, like that's a pretty big difference in R value, right? I mean, we were talking about like, you know, just a 10% reduction in R value, how that would be a, you know, tremendous win for the virus, just in terms of like the heat of the summer months, which unfortunately hasn't proven to be true. But 50% reduction in disease severity or illness at all would be, you know, maybe even enough to get things mostly contained.
Yeah, but the way I'm thinking about this, I guess, is a little different. I didn't explain it very well. My concern is that even if let's say we get a vaccine and it's 60% effective. Well, if every single person got it, then we're doing pretty good. We're going to get pretty close to herd immunity then. But the issue is that what is the public going to do when we've already seen that people are not great at doing things that just help other people, like wearing a mask. And so if you say, yeah, this is a 50-50 chance this is going to help you, I think the percentage of people that are going to be willing to get it is going to be drastically lower as well. So this number makes me a little worried about that, about the public's response more than anything.
Yeah, I wonder if the government would be willing to make it mandatory.
Did you just hear all the heads explode when you said that?
Yeah, actually, I could a little pop in my ear, my left ear.
Yeah. So, Mike, what are you doing for the 4th of July? You going to a big party?
Yeah, we're going to do a giant party with the 4 of us in our backyard.
So that's the concern. As the 4th of July approaches, we just want to put a little PSA out there. Yeah, it's 4th of July is a fun holiday. It's on the weekend, this weekend. But young people out there, and that's who I'm talking about, you got to do a good job this weekend. You got to behave yourself. The percentage of hospitalized coronavirus patients who are between the ages of 18 and 49 has risen from 27% in early March to 35% this week. And that's just because as states have kind of reopened, young people are really coming out in droves. And that's a problem. In Oklahoma, the vast majority of new cases now that have been confirmed since the reopen have been in young people. 50% of the new cases that are diagnosed are under the age of 35, and 70% of the new cases are under the age of 50. So as we think about our 4th of July plans, it's great to go outside, but don't do it around a lot of other people. Right? We're in a difficult spot now with 45,000 cases per day, or however much it is each day. So we got to kind of buckle down, I think, this weekend.
Yeah, I was thinking about this earlier, Matt. I don't mean to be alarmist, and I don't want to come off that way, but I feel like somebody's got to say, like, we got to be careful here. This is not going the right direction, and a lot of states are not halting opening. They're not requiring masks. I think that my wife and I had this conversation yesterday. We're going to dial it back a notch, because I think that's the right thing for the community and for our own safety, because this is going the wrong direction. I mean, we've had the highest case record in our county just yesterday, and that's true in tons of counties and states throughout the country. The virus is more active now than it was weeks ago, and I think people need to recognize that. And if our government's not going to tell people that they need to buckle down, then I'll tell you. I think it's time to buckle down. I think we need to be more careful, wear masks, and make sure we're practicing adequate social distancing.
Yeah, and I wish I could say that I thought your imploring was going to do any good. But yeah, I just feel like people's appetite for that is just over. So the numbers are what they are. So hopefully people will make the smart and safe decision this weekend. You got any research to talk about, Mike?
I got a few things to talk about today. There was a lot of discussion, maybe a month ago or so about multi-system inflammatory syndrome in children. So this is that syndrome that looks a bit like Kawasaki's for people who know what that is. It's a vasculitis that causes inflammation, just a lot of inflammation all throughout the body. And this has been linked to COVID-19, a good bit of discussion about it, some back and forth about how prevalent it truly is and whether it's something we really need to worry about in kids or not. We're finally getting some epidemiologic data that's being published in the literature now regarding the multi-system inflammatory syndrome. So I wanted to just go over that just for our own knowledge. I'm not sure there's going to be a lot of ahas from these studies, but it is nice to know some numbers. So the first one was published June 29th on New England Journal of Medicine, Multi-System Inflammatory Syndrome in U.S. Children and Adults. This was, as both of them are, an epidemiologic study. They talk about 186 cases out of 26 different states. About 70% of these cases were actually positive. So this is RT-PCR positive for SARS-CoV-2. So even though it's only 186 cases, not all of those necessarily had SARS-CoV-2, at least around the time of diagnosis of multi-system inflammatory syndrome. The average age of these kids, 8.3 years, and consistent with COVID, 62% of them were male. So a predominance in males. Yeah.
You said at the beginning, you said U.S. children and adults. You meant children and adolescents. I just wanted to point out this is all in kids in the study. And that age is interesting too. At first we were just thinking about this as just like Kawasaki's, but that age is a little older than Kawasaki's normally is.
Yeah, and that we'll see that's a little bit inconsistent in the literature too. But they've found 8.3 years, which you're right is a little bit older than Kawasaki's. Multi-system organs involved. 92% had GI symptoms, 80% had cardiovascular symptoms, 76% had blood symptoms, hematologic, 74% had mucocutaneous, which means things like rash and oral lesions, and 70% had respiratory symptoms. So respiratory issues, although the most prominent symptom in adults, much less prominent in kids. 80% of these kids ended up going to the ICU. 20% ended up on a ventilator, and around 50% ended up on pressors, which means medications to keep their blood pressure up. Around 10% of them, 8% specifically, had coronary artery aneurysms, which is the big thing that we worry about with Kawasaki's disease, and 40% of them met the criteria for Kawasaki's disease. Overall, 2% died. So overall, a good, much better mortality than adult patients who go to the ICU, but obviously 2% of children is still concerning. The challenging thing about this is this study did not give us a denominator. So we don't know, out of that 186 cases in 26 states, what is the number of kids? What's the total number of kids that got COVID-19? And that's challenging to know because so many of them likely have asymptomatic disease. Similar report came out of New England Journal of Medicine. Again, this one in children with multi-system inflammatory syndrome in New York State. So this is just basically hospitals reporting to the New York State Department of Health. This was published, I think, mid-June, if I'm not mistaken, and data was up through early May. They found 95 patients with confirmed MIS, and 54% of these were male. They also found a predominance in minorities, so 40% Black and 36% Hispanic. And they found more younger kids. So they had 31% in a 0 to 5 age range, 42% in a 6 to 12 age range, and then 26% in a 13 to 20 age range. I like this study because they actually talked about some of the symptoms that the kids were presenting with. So fevers and chills in 97%, 80% had tachycardia, 60% had gastrointestinal syndrome, and 56% had a rash. They also found really high levels of C-reactive protein, D-dimer, and actually troponin, which is interesting because this is helpful for diagnosis, I think, something that you don't typically see elevated in children. 71% had an elevated troponin, which is a marker for cardiovascular damage. They found 62% ended up needing pressors and 53% had myocarditis, which is where the heart doesn't squeeze as well, basically, and they're having difficulty there. And then about 2 died, so near that 2% mortality rate that we saw with the prior study. So I think this is interesting from an epidemiologic standpoint. I don't think it really informs us as to the true prevalence of multi-system inflammatory syndrome in children who have COVID-19, but it does, I think, help inform healthcare providers in what to look for, and I guess better understand the disease process and what organ systems are involved and what the likelihood of progression to things like, aneurysms of coronary arteries is.
Yeah. So in the way I would kind of summarize this too is I initially, when we started seeing these reports, I thought, well, this is just very similar to Kawasaki disease as far as prevalence. It's a really low number. We're talking about it because it's scary and it's kids. But if we look at these numbers, for example, with Kawasaki's disease, and the reason why I'm bringing up Kawasaki's disease is because it's a real thing that's been around a long time, and there's no public outcry about it. If you're listening to this, you're not freaked out about Kawasaki's disease, even though every year it happens, the prevalence is about 1 in 20,000 kids. So if we look at this New York State article, I think, I Googled this at one time, there's about 2 million kids in New York State. And if that's the case, we would kind of assume maybe 100 kids per year in New York State will get Kawasaki's disease, which is pretty similar to these numbers. This is a compressed time period, but it's not that much different. And especially in New York, and especially if you're going to the city where 25% of people may have been exposed, this, in my mind, you're right, we don't have a great denominator here. In the 186 case study, they're talking about over 26 states. But in my mind, when I look at this, I really don't think, I'm just not that much more worried about this than I am my kids getting Kawasaki or having an accident, just being a kid. So it's something to think about, something to watch, but I still don't think the numbers generate, or the numbers are cause for alarm.
I think I'd agree with you on that. I mean, I think we don't truly know the true prevalence of this syndrome, but my sense is, with you, Matt, that it's a similar prevalence of other viral illnesses that we see causing Kawasaki's disease.
Yeah, and maybe some kids that actually got diagnosed with Kawasaki's disease are actually getting this, and so this could be underreported, or it could be the other way. You said 40% of kids met the criteria for Kawasaki's disease. They may have gotten it anyway, other than the fact that there's a pandemic now. So yeah, it's hard to know, but I think the numbers are in line with traditional Kawasaki's, or at least close enough.
Yeah. You want to talk about some antibodies? There's been some new research out about antibodies. The press is picking this up in different ways. One of the ways that they're picking it up is specifically about this first article that we're going to talk about, is suggesting that people are not retaining IgG antibodies to COVID-19. So this is an article that's on medRx, so this has not been peer-reviewed. It is called Prevalence of IgG Antibodies to SARS-CoV-2 in Wuhan, Implications for the Ability to Produce Long-Lasting Protective Antibodies Against SARS-CoV-2. So this study was basically looking at 4 different groups of individuals who received both COVID-19 IgM and IgG test and RT-PCR test for SARS-CoV-2 between the period of April 29th to February 29th to April 29th. A total of 1,470 hospitalized patients. They found IgG prevalence was 89.8% in COVID-19 patients. So these are patients who previously tested positive with RT-PCR, had about a 90% prevalence of IgG. And then when they looked at healthcare workers, they found a 4% prevalence of IgG antibodies or seroconversion in healthcare workers. And then in general workers, a 1% prevalence. They found that IgG prevalence increased significantly by age among healthcare workers and general workers, and the prevalence of IgM antibodies to SARS-CoV-2 was 31.4%. Realistically, that's probably because they didn't test them until like 30 days after the illness, though, which makes sense. The IgM would have gone away by then. Their conclusions are that very few healthcare providers had IgG antibodies to SARS-CoV-2, though a significant proportion of them had been infected with the virus. after SARS-CoV-2 infection, people are unlikely to produce long-lasting protective antibodies against the virus. Matt, what do you think about their conclusions there on the paper?
Well, so they're making a couple assumptions and a couple jumps. The fact that they say the antibodies don't last, they're assuming that they had them, and they didn't actually prove that. They're making the assumption that you're going to produce IgG antibodies when you have the infection. So in their actual patients, they're saying 10% loss. Well, maybe 10% didn't actually form antibodies. And that's actually, I think, the more likely thing based on our experience with testing. So what I mean by that, the healthcare workers, for example, 4% had IgG positive. That doesn't make any sense. These healthcare workers, especially in this study, were being exposed even before we knew about all the PPE stuff and what to do. And I would say probably 25 to 50% of them at some point probably would have tested positive RT-PCR. They didn't test them, but a much, much higher percentage were exposed to and probably had some sort of viral infection, as minor as it may be, and only 4% were IgG positive. I don't think they probably formed the IgG antibodies and lost them. Instead, we've had the experience where, because we're testing so many asymptomatic people like these hospital workers, we've had the experience with a lot of people are testing positive RT-PCR, but if they don't get symptoms, they just never test positive on the IgG antibodies. And it could be that they're producing really low amounts that don't show up or just no amount. Our theory right now, because we're really seeing this in asymptomatic people, is that their innate immune system is probably fighting this off before they really develop enough IgG antibodies, and they don't need that form of the immune system. So I think that's probably more likely what happened. These asymptomatic hospital workers, even though they were exposed, their body was able to fight this off before they made a level of IgG antibodies that would have shown up on the test. In the end, it's the same kind of scary result in that people are not probably going to be as immune later as we initially thought, with the caveat being we don't know that even either. Maybe you get exposed, maybe you develop some level of antibodies that don't show up on these tests, and maybe you are immune. I don't know. But in general, based on everything we know, this would make us a little more worried that people are not going to be immune later on after a minor infection or even sometimes actual COVID in those hospitalized patients. So that means a few things to me. So it means the immunity passports people have talked about before are definitely even more of a worse idea than we thought. It also, if we kind of take this back to the thoughts we were talking about earlier about the vaccine, it kind of questions how effective maybe recombinant or inactivated virus is going to be, because if people are actually getting exposed to this virus and not developing IgG antibodies, it may be that much harder for a large percentage to have immunity after a vaccine, at least the traditional ways we make them. And it also tells me that the COVID party, which some young people are having, where they're like all trying to get it so they develop immunity, that strategy is even more dumb than we thought as well. So those would be my long list of takeaways from this paper.
I wish people would use the word dumb more often when discussing medical theories. One thing that sort of struck me was this idea that only 90% of people who are actually positive with symptoms had IgG antibodies at several weeks after the illness. So, that raises the concern of, okay, well, one, realistically, that could be just within the realm of error from the test, because we know the sensitivity of these antibody tests ranges from like 80 to 90s. So 90% could just be a testing error, but it could also mean that your IgG antibodies are only going to stick around for a certain period of time. And what we don't have is a good study looking at long-term IgG prevalence in patients who were previously positive with COVID-19 and symptomatic. But I think the thought you bring up with the asymptomatic people having less seroconversion is certainly concerning for the concept of a vaccine, and whether we're actually going to be able to develop an effective vaccine that's going to bring with it any true immunity. That is actually along those lines, Matt. There's another study I wanted to talk about. It's called Clinical and Immunologic Assessment
Right before you do that, though, I will make one comment about your thought about the antibody test, serology test just not being sensitive enough, and maybe that's just the amount we miss. That's true. They actually did outline in this paper, though, that the tests that they were using had a reported sensitivity of 98%. So although my very first thought was exactly that. That's probably just how many was missed. I think the fact that the test they were using did have a significantly higher reported sensitivity, it probably does point to some of the concerns that we were having. So, yeah, I think the concerns you laid out are definitely real. This probably wasn't just the operating characteristics based on which test they reported using.
And, all of this does seem consistent with our experience, and then also some other literature that's out there. So another article, Clinical and Immunological Assessment of Asymptomatic SARS-CoV-2 Infections. This was a study that was fairly small. They looked at 37 asymptomatic individuals and basically looked at how long they shed virus and whether they developed a strong immunity to SARS-CoV-2. They found that the median duration of viral shedding in the asymptomatic group was 19 days, which I thought was pretty impressive. And they actually had a longer duration of viral shedding if you were asymptomatic than if you were symptomatic. Now, we don't know if that means that those virus is still infectious. It's possible that you could just be shedding dead viral particles, but I think we have to assume that if you're shedding something, you may very well be infectious. Then they also looked at virus-specific IgG levels in the asymptomatic group and found that they were significantly lower relative to the symptomatic group during the acute phase of the illness. And then 40% of asymptomatic individuals became seronegative compared to only 12.9% of symptomatic individuals that ended up becoming seronegative. That concerns me. So that basically means that these patients, 40% of asymptomatic people, are not really developing a strong IgM or IgG antibody response, which is what we truly need to develop immunity to the virus, right?
Yeah, and I feel just bad seeing this. I have advised some groups when they come to us because they want to do large group testing that, hey, yeah, if you've got some IgG positive people or in the past, maybe you can eliminate those people and save some money. But I don't think I can really recommend that anymore. I think we need some actual surveillance on people who have even had this and have IgG antibodies.
Yeah, unfortunately, I don't think that we're at a point where we can truly use the IgM and IgG antibody testing to determine human behavior. I think we're still stuck with RT-PCR as far as I can tell based on this research and then, of course, all the other previous concerns that we've had.
Yeah, and what I'm not going to do is I'm not going to end this by saying that the solution is testing, because that we've been saying that forever. And the reason I don't want to say that anymore is because we were saying that quite heavily when there was excess capacity in the system. Like I know multiple labs who had a lot more capacity, and now we're in a spot where I'm really worried about the next couple months because it's getting really hard to get reagents again. Like we can get swabs, the machines are there, but just getting the reagents has actually started to be difficult, like it was in kind of March and early April when we had not ramped up capacity. So I'm no longer sounding the alarm bell that we need to do more testing, because I guess we just need to be talking to the people who make reagents and raising the alarm bells that they need to make more reagents, because we're headed into a difficult period in the next few months if cases continue to climb and our percentage of positives continue to climb, and we cannot ramp up this testing. So until we can ramp up the reagents, the biggest thing we should be talking about is, again, like you were saying, Mike, which no one is going to listen, but being more careful and wearing masks. That's kind of where we are right now.
Cool. I think we did a really good job of making this a very positive podcast as compared to the previous 5 or 6. Yeah.
Yeah, for sure. Yeah, we laughed a few times, so there's that.
I'm laughing right now.
Yeah, so that's all you can do. So, yeah, it's going to get better. We'll get more positive at some point. We're not always going to be in this place, but we're going to continue reporting. And we've got a non-COVID podcast coming up in the next couple of days on structured water. It's a really interesting topic. We're going to be talking to some experts in the field of water in general and trying to kind of tease out what's real and what's not real when it comes to health effects. So the first one we're talking about is with Dr. Gerald Pollack on structured water, and we'll release that in a couple of days. Thanks for listening.
Thanks for listening to the Wild Health Podcast. If you found it helpful, give us a 5-star rating and write a review on iTunes. It really helps the podcast, and we greatly appreciate it. If you want to be a client or you want to work with us, go to wildhealth.com. Thanks again.